The next recommendation, the third one, is going to be addressed by Jeff Levi. Jeff has been through a number of these wars, going back to the Clinton administration, and has been a leader in the Trust for America's Health and their annual product. We all look forward to FS and FAT reporting on the state of obesity prevention intervention across the country. Jeff?
Thanks, Morgan. And thank you for having me here this morning. It's an honor to be on the stage with Dr. Satcher and Carmona. And Christy is a force of nature in keeping a coalition together. Not directly related to the community prevention benefit, but definitely related to our discussion around health reform. I want to pick up on something Dr. Carmona said about the growing problem of obesity and this being one of the major causes for medical discharge from the military, and how this is a national security issue. Back in the 60s, one of the things that motivated Lyndon Johnson to support the Medicaid program, and in particular the enhanced children's health benefit within Medicaid, was his shock that so many young men were being rejected for service in the military because they were underweight. And here we are 40 years later in a situation where we have quite the opposite problem. So it's a certain irony, but I think it underscores that this has to be something integrated into our discussion of health reform. If we're going to effectively prevent and treat obesity, we have to have a comprehensive approach. Health reform is not just about what happens in the doctor's office, but it's also what we do as a society to make healthy choices easy choices. So one of our recommendations supports, and I will quote it directly, effective evidence-based, this is not something being pulled out of thin air, evidence-based community programs and policies that encourage and support healthy lifestyles, focus on health literacy, address health disparities, and represent a significant investment in population-based prevention of obesity. So what happens in the community is critical to both preventing obesity and to making clinical interventions associated with obesity work. A doctor can write a prescription for more exercise, but if a patient has no safe place in their neighborhood to walk, that clinical intervention is going to fail. A patient can be counseled about better nutrition, but if he or she lives in a neighborhood where there isn't a supermarket, where there isn't a farmer's market, it's going to be hard to access healthier foods. We can have wonderful, and we have proven successful workplace interventions. But if people return to a community where following the guidance of those workplace interventions, where their families cannot engage in similar healthy activities, those interventions are going to be less successful than they could be. Community programs are about changing the norms in our society about nutrition and physical activity. They're about giving people the tools so they have the information and have the health literacy to understand the information that will lead to improved nutrition and physical activity. And above all, community programs are about removing the social and environmental barriers to healthy lifestyles. This sounds a little vague. So what does it exactly mean? It means different things in different communities. There's no magic bullet, and that makes it harder sometimes to explain to policymakers, but that's the reality. Each community has to design its own approach based on local needs, but they need to be based on the evidence. In one community, it may mean building bike paths and creating safer places for physical activity. In another, it may mean improving the quality of school lunches. In yet another, it could mean sponsoring farmers markets or supporting investment in a new supermarket. Most communities will adopt a series of interventions, not one intervention, but a series of them that together will change the climate in the community so people can eat healthy and be more active. We know these programs work. Over the last several years, a very impressive literature has developed of proven evidence-based interventions, and an even larger list of successful local programs has reinforced the fact that we know we can make a difference in changing the behaviors that lead to obesity. So we're really pleased that both the House and the Senate bills, and there are now multiple Senate bills, with a bill and a working paper, we're getting closer there, make a commitment to community prevention by creating new grant programs to support community interventions. So in the House bill, There are community services grants in the Senate bill. There are community transformation grants as part of a larger package for increased investment in public health. The investment in community prevention represents probably less than 1% of the total cost of these packages. But if health reform is to work, then these components of the pending bills need to remain, or we're going to really undermine the health impact of the insurance reforms that are being considered. You know, we talk a lot about bending the cost curve. I'd like to sort of mention two things in that regard. One is, in this year's F as in Fat report, we looked at obesity rates among those over 65 and those in the 55 to 64-year-old cohort. Those people who are going to be transitioning onto Medicare. Those are direct federal costs. We know that treating obesity is dramatically higher per person. Treating people with obesity, the overall annual healthcare costs of those who are obese are significantly higher than those who are not. And the 55 to 64-year-old cohort is about 10% more obese than the current over 65 cohort. So if we're going to bend the cost curve, we're going to have to address this. So the demonstration programs that Senator Baucus has in his draft and are also incorporated in the House and other House and Senate bills would really, to some degree, target some of that pre-Medicare population to try to focus some of these community interventions and clinical interventions, integrate them so that we can try to bend that cost curve. And we know, at least from some of the work that we've done, that you can get a return on investment on this. The Congressional Budget Office may not know how to score these programs yet, but businesses have invested in them, insurance companies have invested in them, and they are most concerned about the bottom line, and they wouldn't be investing in something that didn't result in cost savings and didn't result in better health outcomes. One last point, and that is community prevention programs, for the most part, reach everyone who's living in a community. So it is both preventing obesity and overweight, and it is also treating obesity and overweight, because improved nutrition and increased physical activity is going to improve the health of everyone, whether they are obese, overweight, or at a healthy weight. So we're really pleased, perfect timing, we're really pleased that this recommendation on community prevention is part of the coalition's overall effort to see that we have a comprehensive